All right, good evening and welcome to the MyCP webinar. My name is Paul Gross and I'll be your host for this evening, back in the saddle. Tonight we're lucky to have Dr. Mary Gannotti talk to us about an update on the Adult Wellbeing and Pain Survey. This is a preliminary report from a study we've been running for about 2 years now. And one of the things maybe we can brainstorm, Mary, at the end is how we can get more people to take this survey, because I think that the kind of findings that we're making with enough volume will be just great. So as always, the way we begin these is I give you a quick overview of the CP Research Network, and then we'll go into the presentation from Mary Gannotti, and then we'll do a Q&A and have an open Q&A. So for those of you that are joining for one of the first times, the CP Research Network is merged in January with CP Now, and we brought together 4 web presences and 2 entities into one organization under the name the Cerebral Palsy Research Network. So our mission is to optimize the lifelong health and wellness of people with cerebral palsy. And we do that by focusing on the whole person, the whole family, and our core programs are in research, education, and community programming. So the concept of a research network is not obvious to everyone. And so what it is in this case is we are a not-for-profit entity under the that we got to with the CP Now brand for what Michelle had created. And what we do is we organize a field of institutions, hospitals, universities, clinicians, therapists, researchers, and all of you in the community as patient advocates to conduct research and quality improvement efforts, which I'll talk about a bit, to improve outcomes for people with CP. Physically, we have a data coordinating center that we contract with at the University of Utah in their Department of Population Health Sciences. And we provide infrastructure that allows this group of people to come together to conduct this research. And the infrastructure that we provide is a clinical registry or a database of information about people with cerebral palsy that's gathered through the course of visits that people make to their clinicians, and a community registry which has information that's collected through surveys about your lived experience. So the clinical registry, the data is coming from the doctors and therapists. In the community registry, the data is coming directly from you. And then with the merge with CP Now, we've really expanded our focus to include education and well-being programs. A big portion of our focus is on this platform called MyCP. What MyCP really is it's a personalized experience on the web that is within the CP Research Network website. And so this portal offers the opportunity to participate in research through these community registries, but also to get engaged in the dialogue about research. All of the clinicians today really want to have people from the community involved as peers in research. And it starts here with the kinds of discussions we have about lived experiences on the forum that's built into MyCP. With the launch of the new CPRN website, we are offering personalized web resources. So if you sign up for MyCP, we'll actually make recommendations to you about the content that is most relevant on the website. And it also gives you access to our fitness program, which is free for 2 days a week. So anybody can sign up at mycp.org or at cprn.org, take you right there. So to give you an idea of this network infrastructure that I talked about, on the left, we have a chart that is showing you for just under 5,000 patients that are in the clinical registry, one of 1,100 data points, up to 1,100 data points that we collect on people. So this is the gross motor function classification scale, which is a critical data point to have to understand the population. And so what you see there along the x-axis is you see the levels 1 through 5, or that it was not assessed or missing. And then on the y-axis, you see the number of patients. And so you can see that what we have represented in the clinical registry kind of makes a bit of a U shape. We have more people that are GMFCS1s and more people that are GMFCS5s. And I actually don't know, maybe Mary can address when we get to Mary about the representativeness of that relative to the population. But the clinical registry is not intended to be population surveillance. So it's not intended to represent things as they would appear in the population. It's intended to represent things as people come into hospitals to be cared for. So it makes sense that it's not directly representative of the population. On the right, we see the membership to MyCP, and this is just to give you an idea. This is actually from a month ago, we had 1,222 members, and you can see the green, the biggest portion, 80% of them are either people with CP or caregivers, and that's split a little more than half of those people are adults with cerebral palsy. So that gives you an idea of the two different sources of data that we collect from. So programmatically, we're very focused on four cornerstones of our work. One is community engagement, and that's a picture of when we brought 45 people together in Chicago in 2017. That was one of our first collaborative efforts between CPRN and CP Now, which was to bring the community and clinician researchers together to set a patient-centered research agenda. And that's really what drives the focus of what we do. We focus a lot on research and quality improvement efforts. And on the right, you see a picture of a number of the investigators on the team gathered together in Michigan. There's Ed Hurwitz there, who is our host, in the purple up in front. And the past two of those meetings have been virtual, but we meet every year to sort of focus on the research that we're doing and advance things. In the lower left, it represents our sort of educational efforts around providing web content and then great resources like the CP Toolkit and the Wellbeing Guide. And then on the right, we represent our well-being programs. And so we've got multiple efforts going in there, but the one that we're focused on most recently is the efforts that we've been making by offering free fitness classes on Tuesdays and Saturdays virtually through Staying Driven with some adaptive trainers who are trained in adaptive fitness training. So the network is spread out across North America. We've got one pin in Toronto there that gives us the ability to say North America rather than the US. Although I did just get an inquiry from, we've been talking to a site in the UK, but we just got an inquiry from Saudi Arabia. So it's getting to be broader and international interest in what we're doing. So the green pins are sites that are collecting data currently. The yellow pins are working through the sort of technology of preparing the registry. The red pins are still doing some of the compliance work. And the blue pins represent sites that have inquired and they want to join, and they haven't gotten to the point that they've been invited to be members, but they're going through some evaluation of the possibilities. So last slide before I turn it over to Dr. Gannotti. This is our pipeline. So we were created to sort of accelerate research. And so what we have on the left is the front of the funnel that is wide, where we'll take, we really encourage idea development at our meetings and whatnot, and people to bring ideas to us. We evaluate them, we move them through to applying for grants, getting approved by an institutional review board for research. And then as it moves down the pipeline, we start to implement the study, conduct the study, and then we write it up. And then we take our learning and we bring it back to the beginning of the process of clinical care. The green ovals represent research projects. The orange ovals represent quality improvement projects, which both are ways to improve outcomes. It's just that clinical research has a certain shape of how it works. Pardon me, I got ahead of myself. And quality improvement works much more rapidly to improve care in the setting of in the clinic or the hospital. Tonight we're going to talk about what we have called the Adult Pro Registry, or the Adult Wellbeing and Chronic Pain Study. And I am really excited to turn it over to Mary Gannotti, who's a physical therapist at Shriner Springfield. She's a professor of physical therapy at the University of Hartford. She's the co-principal investigator of our adult study group, and she's been a member of the CP Research Network steering committee since the beginning. So without further ado, Mary, take it away. Let me unmute you, Mary. I think I'm all powerful.
Thank you, Paul. You're so generous. And I am so blessed to be able to work with this crew of people here at the Cerebral Palsy Research Network, as well as people that I've worked with and other instances where we've tried to work on adult outcomes. Thank you, Lori. So I'm going to give you the update on adult outcomes, and this is the preliminary report on functional changes in pain across the lifespan. And this is our main team, people that contribute to the analysis and interpretation. And this is the July 2021 report. And as Paul said, there's a few more people, at least 3 that added their data today. And I can update the slideshow for him tomorrow, but I don't suspect it'll be earth-shattering changes. This is the mission of the CP Research Network. And these are the institutions and sort of care centers that have worked together to contribute to the adult registry, as well as people that are on the call tonight, particularly calling you out, John and Duncan, and many other people that have contributed, family members, to the items on this panel, on this registry. So to give you a little bit of background, even before we had the grant from PCORI and they did the CP sort of research network agenda setting, we knew this was an issue, but it came up resounding that, what can we do? How we treat adults now? And how do we update our treatment to prevent some of the secondary impairments that people are experiencing? What can we do to stop that cycle? So we formulated a research question. How can we treat and prevent pain, function, and fatigue among adults with cerebral palsy? And we thought with big data that can give us insight, because with training in epidemiology and just knowing about case studies, sometimes you can really learn a lot from just listening to people, whether it's a whole bunch of people or one person. So we wanted to look for patterns for prevention and treatment. So we identified our priorities, which are demographic, functional changes, and pain impact. We got some consensus among our work group and our consumer panel. We identified questions, we piloted them. We had a really rigorous review at the University of Utah and the scientific committee of CPRN. Then it was vetted another time, revised one more time, and then we hit go. And we hit go with the mind that in the future, we are going to have longitudinal data, and that hopefully we'll also link this to the clinical registry, because that's when it's going to be most useful. Because the clinical registry has been vetted for adults. All the items in the clinical registry, and then we add a few, are perfect for adults. So this is how we modeled things. We looked at the CP type and distribution, if there was chronic pain. We did a screening profile on social, emotional, physical health. We also looked at just measures of, physical function, manual function, and how people communicate. And then what did people think about their changes over time? Did they experience some kind of stigma from their CP? And what was overall their demographics in terms of education, income, and employment? So Paul and Michelle, they're so creative and innovative. They opened the platform for taking the surveys in April of 2019. And I think shortly thereafter, I presented about 100, 120 people. So since then, we have 196 or more folks. And as Paul would say, we're 199. We need one more to reach 200. Now, the goal would really to be, I'll tell you what the characteristics would be. Would we have a nice distribution across the age groups and the physical function? But right now, we have more females than males still. We have more whites than we have non-whites. We have a nice distribution of working and not working. They're about middle-aged, and we have the full lifespan. When we look at the age groups, you can see that 18 to 38 is almost exactly equivalent to 38 to 58. But the 58 to 99, which really ends in this sample at 75, is 29%. So it'd be great to get some older adults over 50. Oops. In terms of GMFCS level, representativeness wise, we do see this from the Australian registry, Paul, you're correct, that about 66% are ambulatory with no assisted device and about 33% use assisted devices. These exact percentages do not really lend themselves to statistical analysis. You know, as a statistician, I would like equal amounts, or at least over 50 in each of these groups, to really be able to say something substantial about each GMFCS group. I collapsed some of the groups for analysis. Here we see primarily people can communicate, because we didn't allow for people that could not communicate on the survey. And we have a variety of manual abilities, although most people are very dexterous. So it also lends itself to an online, which would beg the question of proxy for an additional capacity. And demographically begs the question of the Spanish translations, which is available for all of these measures. So who's experiencing changes and why? So we asked the question, who experienced changes in gross motor function since childhood? And it was about 70% of the people. And if you look at the 18 to 38, red is, you know, the decline. And then the 38 to 58 and 58 to 75, it's almost a linear incline in terms of people are going to decline with the age. But the interesting thing that's really fun is that more people improve than decline in ages 18 to 38. So this is a really good window of opportunity. And then look at 38 to 58, there's still people improving. So we have these windows of opportunity for treatment that are perhaps not necessarily targeted, these populations, for treatment. So what type of change was it? You know, for the most part, it's decline. So you look for reasons for gross motor decline or improvement, and the main reason is pain. After that, it's changes in strength, changes in spasticity, and then, you know, perhaps this change is related to people that improved, and we're hoping that the surgery helped people improve also, as did the therapy. But some of these other conditions and progressive deformities would certainly impact your gross motor function. Changes in Communication abilities. Again, there's a change over time. And this change is primarily a decline, but look at more people report improvement rather than decline in ages 18 to 38. And oops, excuse me, with the jumping, oops, jump. Where am I going? Here we go, communication, and I was right here. So, but look at this nice, more people reported improvement than decline with communication. We still have improvement up to age 58, and then 58 to 75, there is still some more improvement. Changes in the hands, we can see an increase over age with a reported decline. Okay, changes and decline. When we ask people about their overall health, well-being, and stigma, we're looking and we see that 50 is what is the average with these promise scores. Naturally, there's less physical function. We're interviewing a population who has physical disabilities. There's more anxiety, slightly more depression, or fatigue, slightly more interference, less satisfaction, participation, more pain, and more stigma. The age wasn't a source associated with any of these scores. And the GMFCS was only associated with physical function, as we would expect. Oops. I think there's a little, oh, it didn't come up. Overall, all of those domains are below what we would expect for the general population. So that was not a very good show of the physical and psychosocial health for people with cerebral palsy. So let's talk about pain. Where is it? How much of it? And what works and what doesn't? So have you had pain that has lasted more than 3 months? And 79% reported yes. And you can see it's almost a U-shaped curve because there are adults with CP that don't have pain, and that's not their primary complaint. Their primary complaint is functional decline. Do you have chronic pain that's lasted more than 3 months? If you looked at ambulators versus non-ambulators, this is 90% versus 98%. Pretty much, there's a lot of pain across the board. And it doesn't really seem if you ambulate or not, or use an excessive assistive device, it matters. The more that you have chronic pain, the more you're at risk for declining. When we think about or look at the reported location, we can see the primary place is the low back, then the lower extremity, but also we have the neck and shoulder. Another consideration is the abdominal pain, which is not necessarily musculoskeletal. Another consideration, which the BPI, which is the measure that we used, is that for people with CP, they're at risk for central pain syndrome. And it's a neurological condition caused by damage to the CNS. And it doesn't matter where it is in the brain or the spinal cord. And it could be caused by stroke, MS, trauma, Parkinson's disease, or cerebral palsy. The pain is typically constant and maybe moderate. It could be made worse by touch, movement, emotions, and cold temperatures. So we don't know how many folks had that, because the central pain syndrome can affect your face, it could affect your shoulder, or other regions. And we undercounted that. We didn't count it at all. Pain intensity and interference. you can see that overall, for the most part, people are high at 5 or above, which means, and that the range is 0 to 10, which means that the pain intensity can be very severe and is interfering significantly with people's daily function. There was no association, again, of age group or GMFCF level with pain intensity or pain interference in any domain. For this slide, the main message is that wherever your pain is, it starts really early in some folks, as early as age 2, 5, 4, 10, 11. And it could be in various places, and it mostly gets worse. And it rarely gets better. The leg, knee, and foot, it didn't get better at all in any of the respondents. The shoulder, hand, and arm, it had the higher likelihood of getting better. But for the most part, people got worse. We need to break this cycle. So here's all the treatments that people tried, but the things that really worked for the neck, surgery's in there, but massage, exercise, physical therapy, no surgery, massage, exercise, physical therapy, exercise, change my function, hot tub, brace, physical therapy. So people tried surgery, but we're not really sure that it's that effective for pain. Again, we're looking at all of these scores for the people that are in pain, and we can see that even more so, that the folks with pain have less satisfaction, more pain, more depression, more anxiety, more stigma, less function than the general population. All the outcomes are poorer than the general population, even more so than the folks who answered the general survey. We look at the opioid use. We had 88 people that have chronic pain, 17 that were using opioids in the last 6 months. The median for their measure was a 4, and the range was 0 to 27. And what that means is that 24% of the people in this sample were at the cutoff score or above for overuse of opioids. So for the discussion and the conclusion, low back, lower and upper extremities, neck, and abdomen are sites that were really painful. Pain interfered with walking, activity, working, and mood to a great extent. Age of onset of pain varied from early childhood to late adulthood. And it mostly got worse. It very rarely got better. Massage was very helpful. Exercise, physical therapy, bracing. Surgery was helpful for the neck, not for the other limbs. Of course, what we're saying is really limited by the sample characteristics. And it would be very important to link this with clinical data to validate it. And it would also really help to monitor care. But it does give us some insights into what we can do to help with adults with CP with pain right now. Massage, exercise, more opportunities to move, and appropriate med management and surgery, particularly for the neck. And let's look out for the next generation. Let's prevent pain or even treat it, because maybe we didn't know, or we didn't even think to ask, or we didn't take it as really meaningful that the child said their foot was painful. But just to let you know, our group has published an article that came out just recently that older adults with CP and musculoskeletal pain diagnoses, they have a greater prevalence of comorbidities and a lower use of PT services relative to their non-CP peers. I want people to choose PT rather than drugs and participate in the CP Research Network. Hope you guys all learned something today. And I don't know if you have any questions or we're up for discussion. But that's the data that I have to share with you.
Thank you very much, Mary. Greatly appreciated. David, glad to see you made it here. Sorry about the late arrival of a link. Let's just open the floor to questions. You can either ask a question in chat if you'd prefer, or you can unmute and just ask the question yourself. But there is a question in chat that I'll just jump to. What were the causes of abdominal pain? I don't know if you had that, but.
I do not have the answer to that. We did not ask them in our database, and that would be an awesome reason to link it to the clinical. Whether it's central pain, the linking of the head and the mood, I don't know.
It is one thing to point out for those of you who watched the webinar that we did with Jacob Keene. We will be down the road be able to do this linking between this survey or the community registry and clinical records if someone's seen at a site that is one of the CPRN sites. So that is a sort of technological problem we know how to solve, and I think is a future area for expanding the research we can do.
Yeah, but generally abdominal pain, and Michelle, you can clue in because you have experience with this, is related, if you're still here, constipation or some kind of food sensitivities like lactose and gluten. So, you know, that requires investigation.
I'm still here.
Very common. Is that something that you think about when you have experience, when Lily experiences abdominal pain?
It's a chronic problem for her.
And
it's related to her GI system.
Yeah.
And
go ahead, Michelle, sorry.
Well, it's very complicated. It's this cycle of, I guess, it's a combination of factors, but it's a cycle of constipation and then fixing that and then revisiting that problem again and just having a sensitive gut.
Yeah, it has to do like mood and diet and
medications
and hydration and exercise. It's really complicated.
There's a growing concern in some of the school-based services. One of my grad students has actually got a presentation accepted at APTA regarding this specific issue of constipation and how that affects kids in schools. So when you mention how this starts, the pain and all of this often starts early, we're talking real early. And unless we get it under control, find out, you know, how many kids are having this issue, how much school do they miss? What can we do in terms of, as you said, Mary, the physical activity, but all the medications these kids are on sometimes as they get older, that again, it doesn't change. I mean, it doesn't get any better sometimes. And I can't tell you how many adults I see. Most of the folks I see right now have either GERD or issues with constipation or other GI stuff that is and can be life-threatening.
My daughter told her doctor 2 days ago that she either feels that she's angry or her stomach hurts. So it's very hard for her.
I'm gonna do a little Q&A management, but Lorraine, can you just say, and maybe it's Lori as I gather Mary's addressing you, what's your background? You're muted.
It's the same as me.
I'm a physical therapist.
Okay, great. Okay, and I want to address the question that was asked, is the survey still open? Yes, it is, and it will stay open until we achieve our enrollment goals. It's free for us to keep it open, but we'd love to get to publishable results sooner rather than later, because we think that it can just help strengthen the story for research and the story for advocating for policy changes. I'm sorry, I said Amanda, I meant Amber. You're up next. Your hand was up.
Yeah, I was gonna piggyback the constipation issue. I know that approximately 60% of all people with CP have constipation in comparison to the general population. And I can say I've had it since day one, but I now have abdominal pain that's been recent. I've lost like 20 pounds in the last year. I can say that's also attributed to, it causes pelvic floor issues, or the other way around, I'm not sure, but I think inactivity because of COVID didn't help that, even though I know it started way before COVID, it just wasn't identified early enough. So I think finding, addressing that a lot earlier, knowing that pelvic floor issues could be an issue for kids with CP, and educating parents and doctors and therapists to be able to give that information to patients and to parents, I think is important, because I'm now looking for somebody who can help me with my GI issues, and really, I'm at a loss. Like I've just, so if you have any ideas of where to refer me, I'd be greatly appreciative, because I'm not gaining weight and I'm not losing any right now, but I'm very fragile. I'll just put it that way. So, but I can just say that yes, the constipation issue leads to many other problems later on in life.
This is certainly something we could put to some of the MDs on the adult panel about these GI issues. I wouldn't be surprised if either Dr. Gary Noritz or Dr. Ed Hurwitz has, a place to refer you to on this, since I think.
Yeah, and one comment I can make, which is, this is a fact that in the autism community, they have linked a brain, gut, mood pathway, and there's a specific immunological profile that is associated with that. And I think that long-term PT requires a lot of, I see that. That's why we have to do more community programs. So I would imagine that working with an immunologist to work on food allergies and thinking about, clean diets to reduce the inflammation in the gut, which is something that you do for IBS anyways, has been life-changing for a lot of people with autism. And maybe it's a similar thing for other people. I've experienced that with a lot of adults that I work with CP. They say, I have celiac disease, Mary. I say, great.
I'd like to ask a question of I see a number of people here who participated in Mentor, and I know Mentor was not CP focused, but I'm curious if any of the gut issues were discussed as part of the nutrition, or if that was too specific in Mentor.
I actually asked Lacey personally if she could help me with constipation, and she gave me some very helpful advice. I've been trying to implement it, but I'm going through a phase where it's not working as well. So I have to probably try and, up my water intake, the heat. I'm sure that's not helping.
Right.
But she did address it personally when I asked.
Okay, but it was a personal thing. It wasn't part of the curriculum where they were talking about it, because I think the issues for CP are a little bit more narrow than the broader, disability community that NICPAD is focused on. So I was just curious. But
she did do a lesson on water and constipation, but I think that was one of the lessons that we were sharing with other mentor groups with other disabilities. So it wasn't specifically CP focused.
That's interesting. Okay. I'm going to try to sort through hands that have been raised and things that have posted. Colleen, you mentioned an issue that I know is near and dear to John Borland's heart and others, and I'm curious if you have a question or just wanted to make the statement, that this is this ongoing issue of, PT is great, but it's, never prescribed in the or covered in the dosage necessary for the needs of the CP community.
Yeah, thank you so much. This is Colleen. I am happy to be here tonight, and thank you for this really informative presentation. I think the data presented and the results presented, indicate what's needed for pain management in a lot of the GMF groups, and it's true. But we also really need to look at the social determinants and impacts of why folks are not seeking out those specific modalities. And I guarantee, if the question for further research was done, qualitative research was done around why folks chose specific modalities, we would find that there is a enormous disincentive to pursue or receive PT in the correct dosage needed longitudinally to impact pain levels. So I think, the information that was provided here, great and not shocking at all. So I was a little bit shocked when I saw that choose PT, because I think it's a little bit, I don't know how I want to, it's one-sided. I think we need to look at the determinants which disallow people to have that choice, and they are significant.
Mary, did you want to comment? You looked like you wanted to comment.
Oh, I totally agree. I don't understand why there's so many barriers to, accessing community programs or individualized exercise programs or adaptive gyms or physical therapy, or however you want to get, however you want to access your physical activity that's going to help you. And I didn't mean it to be a slap in the face, but it is kind of tongue in cheek, I would imagine, because I totally do hear you. But I know that Medicare has approved this so-called, maintenance therapy for certain types. And I do think, Lori's been hanging out with me. We've been teaching the same stuff for the last 15 years. We do need to make exercise more accessible. And if it is through the mentor program, and if it's not through paid PT, it's probably the way it's going to be. I don't really care, but we just have to help people. We have to educate people, families, that, your kid is 2 years old and pain is going to be a huge problem. And let's start dealing with it now and managing it and provide supports and alternatives. I'll take any other conversation.
I'd be curious if community exercise can replace the needs of PT. Like, John Borland, I know you've had specific issues. I'm not expecting that staying driven has replaced your PT needs, but is it known, Mary, as to what degree sort of community adaptive fitness can replace the specific maintenance PT kinds of things?
I think that when the program is somewhat individualized, or if there's specific characteristics. So, we've had great success with BFIT, and then we just have another program that we completed, Hawks in Motion. We were able to individualize it with the coach. And I don't know, with the mentor program, if people were able to experience that. But I think it depends on the mode of delivery, because everybody might need some individualization. And I don't know, but I think that once people learn what to do with themselves, maybe some people on the call can speak to that.
Let me move. Susan, I see your finger up, and I'm going to try to keep working my way down here. John asked, do you know to what degree arthritis contributes to more pain for people with CP, Mary? Is there anything specific that's asked about that or?
So in the paper that Debbie and I just published, we did separate out by those distinct diagnoses. And, the arthritis is increased, as is the osteopenia and the osteoporosis. Yes.
Okay. And you had said something about IBS. I don't know if that was in reference to David's question about has anybody had IBS issues in the past or present? I guess, I do need to learn how to do Zoom polls. I could probably get that answer more quickly that way. Maybe while somebody's speaking, I'll dig in and see
Yeah,
if I can do a
health
poll.
matters. Yeah, you
Uh-huh.
do need to have. So in terms of IBS, my experiences with people with typical development and people with autism, I can't imagine that people with CP are that much different than typical people, so the treatments for IBS are what they are. So I don't have any data on that specifically, but I know that a lot of my adult friends with CP just tell me they have celiac disease, and we just go with it. So I don't think it's between the mitochondrial disease and the IBS. And some people even present with rheumatoid arthritis. So there is a trend in the Peterson articles where they look at comorbidities, and Debbie has in our musculoskeletal one also. These immunological issues do arise, and whether they arise from the chronic stress of having CP, or they arise from the genetic milieu, or the interaction of the environment and the genetics, there is a slightly increased prevalence of some of these immunological diseases like celiac, IBS, and rheumatoid arthritis.
Let me move along. Duncan has waited patiently. He had his hand up a while ago, and I see more hands are up. So I'm going to go ahead, Duncan. The floor is yours.
Real quickly, 40 years ago, I can't believe it, Dr. Kevin Murphy in the Bay Area did a study with Kaiser on urinary and GI issues. It might be interesting to dig up Kevin's research on that. My question, Mary, you talked about massage. Is there a preference or efficacy that is better among professional masseuse, parent, partner, caregiver massage, or self-massage through some type of TENS device?
We didn't dig that deep, but that would be something, to explore to provide people with operative massages. So that important, to have different ways and assess if there's equal efficacy, Duncan. So that's a great idea for Paul and Michelle's support another study. David has his hand up.
Hi there.
Go ahead. So
I just
Mary,
wanted to say, sorry.
Go ahead, David.
I just wanted to say in regards to the last comment about massage, this is my experience. I was very fortunate to find a very good RMT here in Toronto, Canada. And what I found worked for me was not some of the more aggressive massages, as I call it, but what's called the Swedish massage. I found it was just the right amount of tension and massage. I did try some other massage types, but I did find them a little too aggressive for my taste. So I'm just throwing in my comment to the previous person, Duncan.
Okay. I'm going to take back so let me say, I'm going to read Heather's question, then I'm going to go to Susan who raised her hand, and then Amber. So, and then we'll probably be running at the end of the clock here. Heather asked the question, what surgery works for the neck and shoulder pain and who performs it? She was saying she can't get doctors in Canada to take this seriously. So Mary, can you comment on that?
So, I have to dive deeper into the neck, but generally with the neck, it's the spinal fusion or the laminectomy, because the neck is associated with the spinal stenosis and the functional decline. For the shoulder surgery, it's usually bursitis, rotator cuff. And again, we didn't do a deep dive and we don't have the clinical records, but just from overuse, and it would be a rotator cuff repair.
Okay. And then Susan, you raised your hand along there, and then I'm going to turn it to Amber. Do you still have a question, Susan?
Yes, thank you. I think about the use of physical therapy. I think a lot of it relates to insurance, but I think it also, if you could make physical therapy feel more like working out in quotes, I think it would help, because when I got involved in Mentor, I was suddenly excited to tell everyone, oh yes, I work out five days a week, and I have my own trainers, thank you. And then, and then it's like, I mentioned this to my physiatrist the other day, and he was like, hey, you're working out more than me. And it's just a different feeling when you say, yes, I'm attending physical therapy 3 days a week.
Just call them your PT stands for personal trainer. Just call them your personal trainer.
Exactly.
Well, and then, shoot me now, APTA, let's demedicalize, disability.
Thank you, yes.
Amber, you're up.
Yeah, a comment on the IBS, just to piggyback that. I've recently learned that the main cause of IBS is food poisoning. And then that leads to other things. And then my other question to you is, as far as the pain issue, how can, let me see if I can word this correctly. Like, I feel like some of that is due to, like, for instance, I used crutches when I was young, and I don't know if I was taught to use them correctly. Therefore, I think some of my pain now is residual from not having proper technique, and people looking at, or PT, OT specifically looking at those things to prevent some of the things that happen later, but that were a cause of like malalignment and bad use of equipment. I mean, not blaming anybody, just that, I mean, how we're not going to be able to, I don't see how we're going to be able to prevent pain 100% ever, because you can't ever do that in even the population that doesn't have CP. But I feel like it has to be like an ongoing thing from like the time you're born till, because otherwise we can't fix, that as adults.
Well, I will say one thing that I'm excited about that we have going on in CPRN, in addition to this study, is that we've got a group of people that are sort of experts in adult care working on the standardization. And this is, I've reached out to a number of you about a pain panel that we will we'll probably do in August at this stage. I need to have one more meeting of the group. But I'm really excited that we've got this group looking at what's the right way to ask the question to detect this. And Darcy Fellings is contributing. And I think it's going to be a great dialogue. And the goal is to get to something that we can then roll out more broadly, that this is the right way to get at the issues of pain, and then potentially start to look at, can we do a better job in treating it? And so, sadly, you have to start at the very beginning, like Duncan, who's participating in this this effort, said, oh, just asking if I've had chronic pain over the last three months is, that question's not going to work for me. It's not going to get you at what you want. So there's good work going on there.
Can I just say something though, Paul, to Amber?
Sure.
Amber, what you are talking about is a paradigm shift. When we look at a child, we should not look at them, a child with cerebral palsy, and that does not move biomechanically correctly and who has not developed. We should not look at them and say, how can we get them to be normal? We should say, how can we get them to interact maximally with their environment that's going to promote their cognition and their self-esteem, but minimize the joint damage? And I'm really excited about the fact that, physical therapists or people are trying to get kids more active and more involved. And then we need to balance that with joint protection across the lifespan. So it's a paradigm shift for families. It's not that I'm going to do whatever I can to get your kid to run. I'm going to do whatever I can get your kid to be to 45 without knee replacements.
That's great. Yeah, I totally agree.
Let me wrap by saying a couple things. First, Dr. Mary Gannotti, thank you so much again for your efforts in organizing the group of people, both the clinicians as well as the panel of adults that helped shape this. I think this is great. Let me say to all of you, it is great having you here. I love when we do presentations on adult topics, because the adults are just so engaged. And so thanks for all the marvelous Q&A. And then lastly, tell as many friends as you have with CP to go and fill out the adult survey. It's free, it's not fast, but it's free, it's meaningful. And as you can see, we're getting at things that are really going to give us preliminary data. Mary and I were brainstorming about strategies to use this preliminary data to go after some NIH funding. And so that's really, we really want to get the information that'll help us, do the research to make for some change. So thank you all for your engagement. Help us get more people engaged. Good evening.